For our first panelist, we have the president of the Philippine Hospital Association to talk about the economic challenges in operating a hospital during pandemic, which will lay down the foundation of our discussion this afternoon. By the way, all the profiles of our speakers have been uploaded on the website www.health-core.academy in order for us to save time, because reading their CVs will probably take me 2 to 3 minutes, because these people are highly credentialed and they have so many achievements under their belt. I would like to present to you the president of Philippine Hospital Association, Dr. Jaime Almora.
Good afternoon, everyone. I am Dr. Jaime Almora, the president of the Philippine Hospital Association, an organization of about 1,907 hospitals, both government and private. 60% of them are private hospital and 40% are government hospital. I am happy to meet you all in this virtual forum to finally meet the big names, the eminent people of commerce and industry, our officers of BCCI and our banker. Thank you, Ms. Joyce Alomno, the President and CEO of HealthCore, for this opportunity to talk on the topic economic challenges for hospitals during the pandemic. I would like also to greet Ma'am Vergeri, Yosek Vergeri, and Sir Obed. The hospitals have experienced significant economic downturn because of the pandemic. Yes, all the hospitals have experienced and is experiencing significant decrease in economic activity, despite the fact that not all hospitals ended up admitting COVID cases, and despite the fact that not all places in the country have been significantly affected by COVID virus. Our government, through the IATF, was in fact successful in immediately locking down the virus in Manila that prevented it to spread widely to the provinces. It was only until 4 months later, when the economic crunch set in, forcing the government to loosen the quarantine and allowed people, the locally stranded individuals, to go home to their provinces. It was only then that the virus started spreading to some places in the country. That 4 months of a strict lockdown was crucial in allowing the local governments and the hospitals to organize and prepare for the arrival of the virus. When the virus finally arrived in the different populated centers of the country, the identified COVID centers, hospitals, mostly government hospitals, level 2 and level 3, were already ready to accept them. The smaller hospitals, the infirmaries and level 1 hospitals, and some level 2 private hospitals did not have to admit COVID cases. They only triaged them, and the positive cases were referred to the quarantine in the LGU quarantine facilities. Nevertheless, there was and there is 50% to 60% decrease in the economic performance of all the hospitals, regardless whether they have admitted or not. We have in the next slide please. We have in the next slide the indicators of this economic downturn. We have a decrease in the bed occupancy rate, a decrease in the outpatient census, a decrease in the laboratory procedures, decrease in the radiologic procedures, and decrease in the monthly revenues. Next slide, please. Let us start with a decrease in bed occupancy rate. You can see in this bar graph, the bed occupancy rate starting from January 2019 up to October 2020. The one in blue is that of 2019 and yellow is that of 2018. I would like to invite your attention to that period after the declaration of the lockdown from April to October of this year. You would notice that there is a significant decrease in the performance compared to that same period of 2019. Also, something here in this graph is also quite interesting. If you would look at January, February, and March, which was before the lockdown, the performance is still much lower than the performance of the same period in January, February, and March of 2019. So there's something that happened here which caused low admissions. This is not due to the virus because people are still free to go around, to move around. But in this period, if you will recall, this is already the time when the effect of the rice tarification law was set in. This data is from a level 1 private hospital, 50-bed capacity in a rice-producing and agriculture-dependent small city in northern Luzon. So from here, you could see an almost 50% decline in the bed occupancy rate. Next slide, please. And these are the causes of the decline in the bed occupancy rate. There is fear of going to the hospital. There is restriction of movement and travel. There is lack of public transportation. Doctors are not in their clinics. There is a general decrease in the income of the population. In most areas, those in different industries, the workers are not able to go to work, and so they have a decrease in income. And in the rice-producing area and agricultural areas in the country, there is also a decrease in their income despite their harvest because of the effect of the rice tarification law, where there is a decrease in there is no quantitative restriction in the importation of rice, creating glut, and also because of fear of spending. Next slide, please. Okay, here are the causes in the decrease in outpatient census. The decrease in the outpatient is the same reason as the decrease in the bed occupancy rate, the inpatients. There is a general decrease in the infectious diseases like respiratory infection, flu, and dengue. If you look at the graph, the previous graph, this is an unintended beneficial effect of the use of face masks and physical distancing. The face mask and physical distancing prevent these communicable diseases, the respiratory infection, the flu, and the dengue, from being transmitted. And so we have low cases, and that contributes to the decrease in the outpatient census. There are fewer clinics that are open as doctors prefer to do teleconsultation. However, there is an increasing cases of lifestyle diseases, which is related to the sedentary living of people in the quarantine, or people observing isolation. These are hypertension, stroke, diabetes, and obesity. Next slide, please. Okay, there is also a decrease in laboratory procedure. So the same thing that happened to the inpatient, outpatient, there are fewer patients, so there are fewer procedures. The rapid antibody and later the rapid antigen test that came out after few months, in some degree compensated for the decrease in the laboratory procedures. Also, there is an increase in the RT-PCR laboratories. Some tertiary level hospitals investing in putting up RT-PCR testing centers. Next slide, please. Next slide. And another indicator is the decrease in radiologic procedure. Another unintended beneficial effect is the low accident rate, which is one of the most common causes of radiologic procedures, accidents, bone fractures, the limitation in the movement of the people. There are fewer accidents. Next slide, please. And there is a decrease in the monthly revenues of the hospitals. the income has plummeted below 50% after the start of the pandemic. This is seen across all the revenue generating centers of the hospitals except the hemodialysis department. There is also a decrease in about 25% of hospital bed occupancy rate starting in October 2019 until the start of the pandemic. And this is because, like I said a while ago, the decrease in the purchasing power of the people, because this data was from agriculture-dependent hospital, and it is due to the rice tariffication law. And lately, the farmers in most of the country is agriculture in nature, agriculture-dependent, I should say. And most of the farmers lately receive a triple whammy. First was the loss of income from the effect of the rice tariffication law, which started in October 2019. This was followed by a loss of other job opportunities due to the pandemic starting in March and April of this year. And lately, there is loss of their crops to Typhoon Rolly, Quinta, and Ulysses because of the terrible floods in almost the whole of Luzon. Next slide, please. While there was decrease in the revenues of the hospital, there is increase in the expenses because of the structural conversion and construction to provide for triage area, outpatient holding rooms, inpatient isolation rooms, intensive care units, and physical barriers, provision of medical barriers in preparation of and or to receive COVID-19 cases. Regardless whether the hospital has admitted or not, all of them has to provide for these physical facilities. There is also an increase in the purchase of expensive PPE, especially at the outset when the PPE has gone as high as 1,000% higher than the usual price. And also, the hospital has to accommodate their key personnel because there is quarantine and they need to have a travel pass. So and there is no public transportation. We have to be accommodated in the hospital facilities. So there is an increase for their meals and lodging. And also, for those who have to go home, the hospital has to provide them transportation and be shuttled to their houses. And there is an increase in the expenses for hygiene and sanitation, the alcohol and the antiseptic solutions to clean the hospital facilities. And there is an increase in the procurement of medicines, reagents, and other hospital supplies because we have to increase our stock in preparation for a possible surge of patients and that may incapacitate the hospital. Next slide, please. Okay, there are aggravating problems to all these things, and one of them is the decrease in manpower, especially the nurses. This is an interesting and quite extensive topic, so in the interest of time, we'll just pass over it and maybe come back to it in the question and answer time. And there is deficient supply of personal protective equipment and the opportunistic skyrocketing of prices. And of course, you know, the corruption scandal in PhilHealth. There is a restriction in mobility, lack of doctors to receive referrals, lack of suppliers for hospital supplies. There is deficient COVID-19 testing centers. Next slide, please. And there is the unclear pathophysiology of the disease at the outset, which makes diagnosis and treatment a guessing game. And there's no clear therapeutic intervention. Politicalization of the pandemic, mostly in the LGU, they are prone to engage in visually noticeable intervention rather than those that would actually help in the prevention of the spread of the disease. There is general economic downturn in all the industries. And there is that wrongful accusation about the IRM, or the interim reimbursement mechanism, and the case rates, and the accusations of hospitals as causes of fraud in PhilHealth, in failure of PhilHealth to pay reimbursement claims on time. And there are arbitrary denial of reimbursement claims by PhilHealth. Next slide, please. The litany of all those problems is not complete without mentioning the current and future threats to the hospital. And these are the way I see it. Some of the provisions of the universal health care are impossible, ambitious, and ambiguous. There is also an oppressive provision in the universal health care, such as the no balance billing for private hospital admissions, where basically it is moot in academic. The 10% limit for no balance billing is moot in academic because if a patient would request for is an AO being drafted in DOH providing for a fixed copay for non-basic accommodation in private hospitals, despite the absence of such provision in the Universal Healthcare Law. The Universal Healthcare Law provides only that those who are admitted in the non-basic accommodation, meaning the private rooms, may pay for may have a copay, may be charged for a copay. This will adversely affect the quality of healthcare provided to patients, despite the willingness of patients to pay for the best and for all possible care. Another threat is the proposed amendment of the procedures, rules and administrative cases, procedures and rules on administrative cases, which defines the quasi-judicial power of PhilHealth. The amendment proposed to authorize the PhilHealth Regional Office to issue preventive suspension and deny accreditation to healthcare institutions, even without due process and for reasons such as previous conviction of violation or pending investigation of a case. For a mere a trivial violation, a hospital may be suspended, and this means death sentence to a hospital if they are suspended for quite a time, like for example, 4 months and above, and or more. And the access of patients will be affected. The Universal Healthcare Law provides, the purpose of the Universal Healthcare Law is to provide accessible, affordable, and quality care. So if we suspend hospitals, then the community will suffer. And number 6 is the problem with the quasi-judicial power of PhilHealth, where in many cases this is being misused and abused against the hospitals. So those are the future threats of the hospitals. That ends my presentation. Thank you so much.
Thank you so much, Dr. Almora. We have actually already received several questions for you, and we will receive all of them during the open forum. And it was quite interesting to note that agriculture and healthcare are too much intertwined when it comes to economic impact.
HealthCore Academy, your reliable partner for world-class healthcare delivery and patient safety.